Transitioning from an intern to a senior in the ICU can be overwhelming. I have created a series of 3 video presentations to cover some of the most commonly encountered topics in the ICU in the hopes that it will make this transition a little easier. The first video is about vasopressors. So before we get into vasopressors, let's first talk about shock. So shock is defined as a state of tissue hypoxia, which can either be due to decreased oxygen delivery, increased oxygen consumption, or inadequate oxygenation. Traditionally, shock is categorized into 4 categories: hypovolemic, cardiogenic, obstructive, and distributive. So hypovolemic shock is caused by anything that leads to intravascular fluid depletion, and namely either blood loss or water loss. The most common reasons we see this is hemorrhagic shock, volume depletion from GI losses, or third spacing from leaking capillary bloods, such as in patients with burns. Clinically, these patients will present with tachycardia, cool and clammy extremities, and flat neck veins. Cardiogenic shock occurs when you have a diminished stroke volume. This can occur in cases such as a myocardial infarction, acute valvular disease such as acute mitral valve regurgitation, acute decompensated heart failure, arrhythmias, or myocarditis. Clinically, the patient will have cool and clammy extremities, may have oliguria, tachycardia, and you will often see JVD and pulmonary edema. Obstructive shock is secondary to anything that leads to impeded forward blood flow. This can include things such as attention pneumothorax, pulmonary embolism, or cardiac tamponade. Clinically, there is no specific sign or symptom that relates to it, but it can present as hypovolemic shock and cardiogenic shock. If you are suspicious, you must rule out the above 3 immediately because the window to intervene on these is very short. Distributive shock is defined by high output with low systemic vascular resistance. Most commonly, we see this as a systemic inflammatory response syndrome, such as SIRS, and we know this clinically as septic shock. And other causes can include endocrine dysfunction, such as thyrotoxicosis and adrenal crisis, or spinal cord injury, such as neurogenic shock. This too has variable clinical features. So, before we get to the vasopressors, let's talk a little bit about the different receptors that are located in our body. So from our heart, we will perfuse these vital organs. Here I have included the brain, the liver, and the kidney. So peripherally on our vasculature, you have alpha-1 receptors. Alpha-1 receptors, when activated, will cause vasoconstriction and therefore an increase in blood pressure. You also have beta-2 receptors located peripherally, and when beta-2 is stimulated, it will lead to vasodilatation. On the heart, we have beta-1 receptors, and beta-1 receptors will lead to increased heart rate and contractility. And peripherally, you also have dopaminergic receptors, and the dopaminergic receptors will also lead to vasodilatation. So, across the top, I have listed the most commonly used vasopressors, and along the side, I have listed the different receptors. So going through one by one. So the first vasopressor written here is vasopressin, or otherwise known as pitressin. And this actually affects a very specific type of receptor, the arginine vasopressin 1 alpha receptor. Vasopressin exclusively affects only this receptor, and we'll talk a little bit further about what this does. Phenylephrine, also known as neosynephrine or NEO, as you'll hear in the ICU, affects purely alpha-1. Norepinephrine, or Levophed, or Levo, affects alpha-1, beta-1, and beta-2. But as you can see here, it affects alpha-1 much more than beta-1, which is more than beta-2. So overall, the effect on alpha 1 and beta 1 will outweigh the effect of beta 2. Dopamine is a dose-dependent medication, so I'll talk about that further, but that affects alpha 1, beta 2, and dopamine depending on the strength of the dopamine that you use. Epinephrine, similar to norepinephrine, also affects alpha 1, beta 1, and beta 2. Between epinephrine and norepinephrine, epinephrine has more of an effect on beta 1 and beta 2 than norepinephrine. And lastly, dobutamine affects alpha 1, beta 1, and beta 2. However, it has a more prominent effect on the beta receptors than the alpha receptors, and more on beta 1 than beta 2. So vasopressin is the first one we'll talk about. Vasopressin causes vasoconstriction via its effect on the arginine vasopressin receptor 1A that is located on the liver, kidney, peripheral vasculature, and brain. It is usually used as a second-line agent in septic shock, primarily if a catecholamine effusion such as levofed is not sufficient to increase blood pressure. And the most common side effect of vasopressin is bradycardia. Phenylephrine or neosynephrine is a pure alpha-1 agonist that causes vasoconstriction. You'll see it used in neurogenic shock and also second or third line agent in septic shock. You may see it used as a first line agent in septic shock if levofed or norepinephrine cannot be tolerated due to its beta 1 effect. And the adverse reaction similar to vasopressin is also reflex bradycardia. Of note, midodrine is like a PO version of phenylephrine as it is also a pure alpha-1 agonist. Norepinephrine, or levofed, acts as a catecholamine and its most effect is on alpha-1 and beta-1. It can increase peripheral vascular resistance by acting on alpha-1, causing an increase in blood pressure, and it can cause increased cardiac contractility by affecting beta-1 to increase cardiac output. It is a first-line treatment of hypotension, and most often it is first-line in septic shock. Increased risk of cardiac arrhythmias are an adverse side effect due to its effect on beta-1, and sometimes you'll have some reflex bradycardia due to an increase in systemic vascular resistance to the feedback loop. One thing to also note when we give levofed peripherally is that it can also cause skin necrosis. Epinephrine, like norepinephrine, has both alpha and beta activity, but it has more beta than norepinephrine. At first glance, this seems like a very good vasopressor because it's affecting alpha-1 and beta-1, but it has a lot of adverse effects. So first line for epinephrine is for CPR and anaphylactic shock, and it can also be used in refractory hypotension and septic shock as a third or fourth line agent. Adverse effects include tachyarrhythmia, pulmonary hypertension, lactic acidosis, and even hyperglycemia. So dopamine, as we talked about previously, is a dose-dependent medication. So at low doses, it leads to vasodilatation in the renal and mesenteric arteries. Previously, there was something known as a renal dosing of dopamine, i.e. low dose of dopamine, which was thought to have increased renal outcomes, but it has been shown not to have improved renal outcomes. So at low dose, dopamine affects the dopamine receptors. At an intermediate dose, dopamine will affect the dopamine and the beta-1 receptors, therefore increasing inotropy. It also does have a small effect on vasoconstriction at an intermediate dose. And at a high dose, it affects dopamine, beta-1, and alpha-1 receptors. So it leads to increased inotropy, chronotropy, and vasoconstriction. Normally, we use dopamine in cardiogenic shock, especially in patients with bradyarrhythmias, and the adverse effect is tachyarrhythmia. And lastly, dobutamine. It has primarily beta adrenergic activity, affecting beta 1 and beta 2, and it causes, therefore, increased inotropy but vasodilatation. It can be used in cardiogenic shock, and sometimes you can use it in septic shock if there is low output state due to myocardial dysfunction. Adverse effects of dobutamine, as with dopamine because it affects beta, is tachyarrhythmia, and it can also increase risk of myocardial infarction in certain patients, and it can also lead to hypotension due to its effect on beta 2.